is the most common endocrine disorder in a women of a reproductive age group. In this video or in this slide, we can see two pictures. One is of the normal ovaries on the right side, and the left side we can see a polycystic ovary. So in the normal ovary, we can see follicles, developing follicles, then corpus luteum. But in the polycystic ovaries, we can see only a number of follicles, more than 20 in number, and it is not growing. The growth is arrested at some age. This is what happening in a case of PCOS, the polycystic ovary. That means cystic ovary. The follicles, the growth of follicles get arrested at some age, at some point, and there is no further ovulation and no corpus luteum is found in the polycystic ovaries. So polycystic ovaries or polycystic ovarian syndrome is one of the cause of infertility due to anovulation. And it is also one of the cause of secondary amenorrhea. This condition, polycystic ovarian syndrome, was first described by Steen and Leventhal as a case of amenorrhea, obesity, and hirsutism associated with the enlarged ovaries. Now, the diagnosis of polycystic ovarian syndrome is based on the criteria. That is, the ASMR criteria is that presence of two of the following three symptoms should be there. That means oligo or anovulation, then hyperandrogenism, polycystic ovaries. Any of the two should be there to diagnose as a case of polycystic ovarian syndrome. So oligo or anovulation, there should be anovulatory cycles, or that means absence of ovulation should be there, or oligo-ovulation. That means not all the cycles are ovulatory. Only some of the cycles are only ovulatory. That means the ovulatory cycles are very less. Infrequent ovulation is only there. Then hyperandrogenism. The hyperandrogenism should be clinically or biochemically. That is, we have to see it clinically. The presence of hyperandrogenism with the symptoms of acne, then acanthosis nigricans, then hair loss, etc. Or biochemically, that is by clinical, that means by investigations, by the serum values should be raised. The serum value of testosterone should be raised. So either clinically or biochemically, there should be hyperandrogenism. Then the presence of polycystic ovaries in imaging studies. So the presence of any two of the three symptoms should be there to diagnose a case of polycystic ovarian syndrome. Oligo or anovulation, then hyperandrogenism, polycystic ovaries. Then what are the clinical features of polycystic ovarian syndrome? So many of the patients come to our OPD with patients usually complaints of obesity, increasing obesity. The obesity is usually central obesity. The abdominal circumference is increasing. Then cases are with menstrual abnormalities also. That means with oligomenorrhea, then dysfunctional uterine bleeding or amenorrhea. The cycles interval may be increased. The interval may be increased to greater than 35 days, or dysfunctional uterine bleeding is present, or amenorrhea, mere absence of menstruation is also there. Then patients' complaints of infertility. So these are the frequent symptoms seen in our OPD. That means with the obesity, menstrual abnormalities, or with infertility. And the PCOS is otherwise called a hair and syndrome. That means HA for hyperandrogenism, IR for insulin resistance, and AN for acanthosis nigricans. So PCOS is a syndrome of hyperandrogenism, insulin resistance, and acanthosis nigricans. So these are the symptoms. First one we can see acne. In the second picture, we can see acanthosis nigricans. These result from hyperandrogenism. Acanthosis nigricans is usually the skin is thickened and it becomes gray, darkened. This acanthosis nigricans is usually present over the nape of neck, in the groin region, and in the axilla. Then hirsutism, hair growth at the chin, at the chin, in the upper lip, etc. are seen. Then obesity, central obesity can be seen in cases of PCOS. Then irregular menses, either oligomenorrhea or dysfunctional uterine bleeding is also seen. Then hair loss. Male pattern hair loss is seen due to the increasing testosterone or hyperandrogenism. Then infertility are also seen due to PCOS. So these are the symptoms seen in cases of polycystic ovarian syndrome. So what are the investigations we have to go for? Then when we go for an imaging study, in the ultrasonogram, we can see the ovarian volume is increased. The ovarian volume may be greater than 10 centimeter cube. Then the follicles are arranged peripherally. The follicular growth is arrested. So the follicles are arranged usually peripherally. There is no dominant follicle seen. Then the size of these follicles are 2 to 9 mm only, with 9 mm, and the number of follicles is greater than 20. In a case of PCOS, in the imaging study, we can see the ovarian volume increased. The follicular growth is arrested. There is multiple follicle peripherally arranged in the ovary that is greater than 20 in number, and the size is not increasing. The growth of follicles are arrested at a stage, and the size of the follicle is only 2 to 9 mm. Then coming to the serum values, by hormonal estimation, we can see the luteinizing hormone is to follicular stimulating hormone. The ratio is increased to greater than 3. Then the sex hormone binding globulin is reduced. Then estrogen, then testosterone, dihydroepiandrosterone, androstenedione. These testosterone levels are usually elevated. In 20% of cases, we can also see the prolactin level is also increasing. Then when we have also to check the lipid profile. Then to assess the insulin resistance, we have to go for the 2 hours oral glucose tolerance test. So these are the investigations usually done by that is ultrasonogram to assess the size of the ovary. Then for hormonal assay, LH, FSH, testosterone, then lipid profile, then oral glucose tolerance test. So these are the tests usually done. Coming to the differential diagnosis, the differential diagnosis of hirsutism and oligomenorrhea are thyroid dysfunction. We have to rule out all these conditions. Then only we can diagnose it as a case of PCOS. And congenital adrenal hyperplasia, thyroid dysfunction, Cushing syndrome, then benign and malignant androgen secreting or tumors of the ovaries. These are cases of elevating testosterone, this benign and malignant androgen secreting or ovaries. So we have to rule out all these diseases to diagnose a case of polycystic ovarian syndrome. So what are the long-term health risk of this polycystic ovarian syndrome? The long-term risks are when a patient is left untreated, she may get affected with diabetes mellitus, then endometrial carcinoma, dyslipidemia, hypertension, cardiovascular disease, then coronary artery disease. So these are the long-term risk of polycystic ovarian syndrome. Coming to the management of polycystic ovarian syndrome. In polycystic ovarian syndrome, it needs individualization of the patient. The treatment of each patient varies. By non-pharmacological methods, we can advise exercise, diet, and change in lifestyle. Since it is a lifestyle disorder, we have to advise the patient to change their lifestyle, to reduce the weight in case of obese patient, to change the diet, to do exercises. In obese patients, we have to reduce the BMI to less than 25. Then coming to the pharmacological methods of management, uh, if the patient is not desired for fertility, we can use combined oral contraceptive pills to regulate the menstrual cycle. Then anti-androgens can be used to reduce the hirsutism, hyperandrogenism. Then metformin to manage the insulin resistance. If the lady is desired of fertility, that means she is having subfertility. If she is having subfertility, we can go for ovulation induction with letrozole. Then clomiphene citrate, etc., can be used. Then metformin can also be added to manage the insulin resistance. So the management of PCOS is based on whether she is desiring of fertility or not. Then also lifestyle modifications should be advised. Coming to the surgical methods, laparoscopic ovarian drilling is done as a surgical management. So we have studied about polycystic ovarian syndrome, then how it can be diagnosed, what are the clinical features seen, what are the investigations done, and what is its management. So coming to its diagnosis in terms of Ayurvedic term, we can compare it with Artavakshaya. Since in Artavakshaya, Yadojida Kalam Adarshana of Artava is seen. So in PCOS also we can see irregular menses or mere absence of menstruation is seen as like that of Nashtartava. And Avarana is also a concept in Nashtartava. Here also in obese cases we can correlate with Nashtartava since Avarana is also there. Then Staulya, in obese patients, we have to go for the treatment of for Staulya also. So Staulya Hara treatment is also beneficial in PCOS. Then Ashrukdara treatment, if needed, can also be done in PCOS. So the management is like that based on its symptoms. If amenorrhea presents, we have to go for the management of Artavakshaya, Nashtartava, etc. If there is Staulya associated with this, we have to go for the Staulya Hara treatment. Then the Avrita Vada should also be considered here. So the common yogas we are practicing are Varanadi Kashaya, then Gugulu Panjabala Churna, Lohasavam, Varachurnam, Kalyanagam Kashayam in case of lean PCOS. Then we have to advise yoga in case of stress-related PCOS, then Udvartanam as in case of IP management, etc. So the treatment is mainly based on its symptoms. And Stauli Hara treatment should be done. And Grandihara treatment also can be adopted here. Under Vidradi Chikitsa can also be done. Since in polycystic to reduce the or to control the polycystic ovaries. So these are the treatment modalities usually followed in cases of polycystic ovarian syndrome. Thank you.